gyri, sulci and bulges. I would like to invite Dr. Roy Potankar, sir, for the first lecture.
Good morning. I'm not a very good hernia surgeon, which is probably the reason why Ram gave me a talk, a non-surgical talk. And this is generally what I do when I go to various meetings. But unfortunately, because of these two guys you see on the screen, I wasn't able to do neither fall asleep nor spend time socializing. My talk is going to be on making of a surgeon. My disclosures. My references and quotes are from my personal experience. Any coincidence in the narration are deliberate. Experience shared are true to the core, bathed in blood, sweat, and sometimes the patient's bile. Occult mentions are deliberately intentional. And finally, this is an account of mistakes I've made in my life, lessons I have learned, and serendipity found. To me, there are three kinds of surgeons, and I think in this audience are all the competent, the expert surgeons, the ones who have broken the passion barrier and learn and improve their techniques as they progress in life. But to do that, for the youngsters in the back, you need to move outside your comfort zone. What you've learned in residency and early days of your career no longer hold true. You need to get out of the fear zone, and I've been part of this in the journey of laparoscopy and robotics. I've always found excuses. I'm busy, I have many cases to do, my patients can't afford robotics, too many complications, there is a morbidity, but unless you move out of that, you don't enter the learning zone and the growth zone. So ladies and gentlemen, I believe, and this is again sort of my feelings, is you need to upskill yourself, you need to have data science built into yourself, and most importantly, build a team. Something we don't do very often in India. And I'm proud to say my colleagues, Dr. Urvin, Dr. Vishaka, Dr. Prasad are here, and they're all better hernia surgeons than I am. And I'm proud that these young guys do much better hernia surgery and look after that part of the department for me. So it's important, if you're going to move forward and develop a high volume center, you need to build a team of very talented individuals around you. I get 5 residents entering my department, and they all want to learn the techniques of anterior section, esophageectomy. But I keep telling them, better surgeons know surgery is more cerebral than technical. Attending meetings, YouTube, seeing videos, but this is a famous management story in a South American country. A bridge was built, not realizing the river was changing course. I've made many such mistakes. I was a big proponent of notes, of single incision laparoscopic surgery. I spent many hours in the pig lab learning these techniques, not realizing the river was changing course. You need to identify what is called the circle of competence. The inner circle of competence is what you actually think you can say. So if I tell you I can do a reasonably good anterior resection or a fundoplication or AKA laser, I'm probably right. But the outer circle is what we think we know. So if I tell you I can do a laparoscopic TAR or a laparoscopic Whipples, this is what I think I know, but it's not really true, because to do that you need the volumes and the skills for that. How does a surgeon overcome this? First is, be very clear in your mind what is the perimeter of your circle of competence. Slow down, work to expand the circle, and never fool yourself. Talking to various faculty delegates yesterday at breakfast, the common talk is, I do 100 TARs a year, I do 75 CA rectums, and usually it is magnified by process of 5 at least. You need to be somewhere in the center to be what I call sensible medicine. Don't be skeptical of new evidence, neither be hawkishly interventionist. You don't need to learn and do every new technique that comes in. Let the technique mature. POEM and ETEP is a good example of this. You need to be very careful to audit your own results to see how your patients are doing well, but don't be medically nihilistic either. Remain somewhere in the center to offer the best for your patients. This is generally what we have. We are all biased. And when we see a new study, the study validates your preconceived beliefs, you hardly read that paper. It must be a good study. I was right all along. I'm a genius. But if it doesn't, then you're going to spend 20 times the amount of time reading that paper, carefully looking at material methods. The statistics is wrong. It's probably an industry-sponsored paper. Small sample size, and I was right all along remains. This is what's called the Texas sharpshooter fallacy. This is a guy who shoots at a board randomly, like various hernia techniques that we do, and then draws a circle conveniently where his shots are fired. This is often what I see in the world of hernia surgery. We have preconceived beliefs, we pick out the evidence and pick out our own results which fit into that Texas sharpshooter fallacy. So what you want to do is stay in the center, the ikigai. What does the world need? Does it really need a lot of trained hernia surgeons? Can every general surgeon do complex hernias? These are questions I can't answer. The second is what you love, what you're good at, and obviously what you can be paid for. I'm also an entrepreneur. I employ almost 400 people, so I need to pay the salary checks and look after them as I go on, so that's important. The second part of my talk is about failures, and I've had a lot of failures in my life, so I'm well qualified to give this talk. As René Leary said, every surgeon carries within him a small cemetery where from time to time he goes to pray, a place of bitterness and regret where he must look for explanations for his failure. So shit happens, you all know that. When a new technique comes, you think you know everything, you go out from AWR Con in Chennai, the next two hernias are going to be TARS and ETEPs. And then you get a PRS disruption, you get a mesh infection, you get a post-op obstruction, and then you think, guys, there's more to it than I thought. And then you have a major disaster, you think, I'm never going to understand this. And with gray hair or no hair like some people in this audience, you then realize it's complicated. I need to think about this and analyze what I'm doing. So ladies and gentlemen, as I say, decisions are more important than incisions. It's a cognitive process of choosing the best among alternatives and beautifully fits umbilical hernias. I was hearing the session this morning. So 2 centimeter, 3 centimeter umbilical hernia, diastasis, no diastasis, obesity, diabetes. There are many choices we have. The decisions you make are going to be important for you, and results of surgery, like everything in life, including marriage, are dependent on decisions. Only our decisions they can be life-saving or can be lethal, but more importantly, major morbidity not only leaves a scar on the patient, but potentially on the surgeon's mind himself, the second victim as they called. And I can vividly remember my bile duct injuries, my leaked anastomosis, my PRS disruptions, and I tell every fellow who joins me is made abreast of the complications I've had in life. So this is one of our problems which I and Dr. Vishaka managed together. Infected mesh, atypical mycobacteria, disaster, patient was in hospital, whack dressings, higher antibiotics, big trouble. So no matter what measures we take, doctors will continue to falter. It is unreasonable to ask we achieve perfection. What is reasonable is to ask we never cease to aim for perfection. But remember, nature is more powerful and we are not God. I used to work part-time for the Indian Air Force earlier. And I was at the Goa Naval Base one morning, gone to do surgery there, and I realized that the earlier day, a MiG-29 had crashed and a young 23-year-old pilot had died. So there was a general pall of mourning. There was no dinner in the mess. There was no drinks. The next morning, however, 7 in the morning, the entire squadron of the IFF, led by the squadron leader, who himself flew a MiG-29, was in the sky at 7 in the morning. So life must go on. As they say, the best post-operative care you can do is what you do on the table. You need to have a plan B. As Dr. Shikhande would tell me, a good mountaineer knows his way down the mountain. You divided the tar on both sides and your PRS is not coming together. What are you going to do? You have an enterotomy on table during a complex hernia. What are you going to do? You have a plan B and a plan C in your mind. Remember, do your research before. You're not the first to fail. It must be somewhere in literature. Read, and read. And remember, miracles don't happen in surgery. You need to be careful of what you're doing. In response to failure, it's common to become the second victim, to blame yourself. I wish the patient had not come to me. I wish I had not done this ETEP. And finally, why did I ever do surgery in the first place? Don't brood, support the team. Important if you, and I'll give you an example. One of my colleagues doing a lap umbilical hernia injured the jejunum, which we didn't see on table. Day 4, patient was readmitted with perforative peritonitis, in shock. Had to do a laparotomy, had to do a feeding jejunostomy, bring out a stoma. A disaster for a simple 28-year-old lady who had a simple umbilical hernia of 3 centimeters. So the first thing I did was the next umbilical hernia, I made sure the same surgeon does it, assisted by me. That is what a leader must do, support a young surgeon during his times of difficulty, which never happened to me as a learning. I remember vividly my first fundoplication in India after I came back from England had a RAP migration. And the then head of unit, and who was also the HOD, told me, in this hospital there will be no laparoscopic surgery except gallbladder. This is how generally senior surgeons would react early days, and it's important that you do this. Again, coming on to my own life, I divide my life in two parts. I had a CABG done 4 years ago, and I divide my life in two parts, pre-CABG and post-CABG. Pre-CABG, I was busy chasing life's big pleasures, missing out on the smaller ones. My days were typically 16, 17-hour days. Life reflected outward success, but completely bankrupt in inner significance. I wanted to be famous, admired, and honored. I wanted to be rich, but most of all, wanted to be wanted. So that was the story of my life. But as you know, ladies and gentlemen, there is something called the law of diminishing returns. Generally, satisfaction decreases as you get more of the same thing. Is it enough to do 100 hiatus hernias a year? Is it enough to do 10 redos a year? As time goes, you don't get the same kick, the same adrenaline surge anymore. It is what is called the hedonic treadmill. The happiness you get from achieving goals that you set for yourself is often temporary. We adapt, and within no time, we're seeking new desires. And it's true for most people in this audience as well. For the youngsters in your audience, don't compare your chapter 1 to somebody's chapter 20. If Ramana is sitting in the front or Pramod Shinde is here, it's after 30 years of bloody hard work in the periphery of Nasik, working his bottom off to get where he is today. But this is what life is on social media. It's always beautiful. It's all the likes and friends, and it's all rubbish if you ask me. A surgeon, if you like, is like a juggler with 3 balls. You know, you have 3 balls, you keep tossing. One is your professional life, one is your personal life, and the third is your social commitment. It's almost inevitable, ladies and gentlemen, when one ball is very high, the other 2 balls remain down. So it's important to strike the right balance in your life. I'm not sure I've achieved it, I'm working on it. But as they say, it's a short trip, enjoy it. Pre-CABG, if you had asked me how to measure success, number 1 was surgical volumes. I do 25 cases, and I still do 25 cases a day, but I was proud of it. I'm not so proud. It's good, but it's not great. The second is job title, Director of Surgical Services, Treasurer of X Association, AWRSC Chairman. These things are there for a couple of years. You have that medallion around your neck, but life moves on. Nobody remembers who the second man on the moon was. Today, I think it's important to put money in relationships, your own health, and also things like enjoyment time, and to a lesser extent, income, job title, and surgical volume, because I think in this audience, I don't think anyone starves. It doesn't mean you should be complacent. There is a thin line between complacency and contentment. So being satisfied with what we have doesn't mean we stop trying to be better, and that's why all of you are here in this audience. At 8 in the morning, the hall was full. We can be happy with our today and still want to make our tomorrow even more beautiful. The difference between greed and growth is in our attitude and approach. A lot of people think being a good surgeon means clinically good, technically good, but life is a lot more than that. You need technical skill, you need practice, you need a sound clinical judgment, you need to build a team of people, need to look after yourself, be a good mentor to younger surgeons, and most importantly, remain humble. Your ego, your hubris is the one that destroys you. This is an article in JAMA Surgery called Optimizing Joy in Surgery. It says, be grateful, be a good leader, be a teacher, be intentional, accept coaching from people around you. And I still have 2 of my seniors, Dr. Supia and Dr. Mathur, and I often ask them to critique my routine procedures, anterior resection, a nephrectomy, which you do, robotic surgery. I still ask them to critique me. You accept coaching, cultivate compassion, stay involved in the community, and most importantly, ladies and gentlemen, learn to laugh at yourself. Don't take yourself too seriously. Particularly for the first 2 rows, this is extremely important. And my last slide is from a friend of mine, Dr. Pai. It says, when my death taketh me, I'll be ready. In fear I shall not be. Why fear one's tomorrow? At my funeral I crave for tales of joy, not tears of sorrow. My grave deserves no bouquet, my tombstone will need no epithet. When I go to the other side, when I cross the great divide, what use my power, money, and fame? All in afterlife that remains is one's name. Riches are with weakness fraught, not a tomb or mausoleum in my name I desire, nor a gilded grave I require. My role now, ladies and gentlemen, is to mentor young surgeons that training deserve, in hope that with kindness mankind they will serve. Let my name be etched in hearts and souls of those I train and mentor, immortality I desire in hearts and souls of those who have trained and mentored. Thank you very much.